Good morning and welcome to Hope Hospice's Family Caregiver Education Series. I'm Debbie Emerson, Hope's community health educator and certified dementia practitioner. My primary responsibility at Hope is developing and managing the Family Caregiver Education Program. And my goal is always to bring presentations to you that contain valuable information about all aspects of providing care for those we love. So we offer webinars every month on topics that are relevant to those caring for an elderly or chronically ill loved one, including those with dementia. And a complete listing of our webinars for next year can be found on our website. And we have several new classes, so I hope you're going to take a look at that. Now, today we're fortunate to have as our guest speaker, Jennifer Pardini, the Community Education Coordinator at the Health Insurance Counseling and Advocacy Program of Alameda County. Now, by the way, HICAP is every county has a HICAP office, but since Medicare is a federal program, the information that Jenny's going to be sharing today pertains to all counties. And when it doesn't, I know she'll let us know. On the resource list, I've given you a link that gives you websites for all of the HICAP offices in the state of California. And some are not called HICAP. Some of them have different titles or different acronyms, but the link that I gave you will direct you to the place that you need to be.
So thank you for having me. We are going to talk about changes for next year, and I will let you know when stuff is county specific, which mostly will apply under the Part C Medicare Advantage section. But we'll talk more about that when we get there. I am from Legal Assistance for Seniors. Our mission is to ensure the independence and dignity of seniors by protecting their legal rights through education, counseling, and advocacy. What does that mean? It means that we have a legal department, and I'll explain the legal services we offer. I'm from the Community Education Department. And then we have individual one-on-one Medicare counseling available through the HICAP program. All services are free. We are a nonprofit that has been serving older adults in Alameda County since 1976. Our attorneys can help in the areas of benefits. So if someone is enrolled in Social Security, SSI, or the Cash Assistance Program for immigrants, and they have a problem, they can come to us for help. So we're not here to enroll people, but we're here to help people who are enrolled when they need us. We can help with immigration as far as renewing green cards, or if someone wants to become a citizen, we can help with the court and paperwork process as long as they're already a legal permanent resident. In the area of elder abuse, we do civil cases. If it is a criminal case, we would refer it over to the DA. But if someone needs help with an elder abuse issue and they need a restraining order, or they need help with accessing certain benefits that they may qualify for, we can help them with all of that, making sure that supports are in place for them. Kin caregiver refers to our guardianship program. That's our lowest age threshold for anything. So all of our programs are based on age. All of our services, as I said, are free. I'll probably repeat that a few more times. So things like elder abuse are legally defined at age 65. So the client would have to be 65 coming in with their issue. Kin caregiver is 50. So if someone's 50 or older and they're taking care of someone under the age of 18 and they want to be their legal guardian, we can help with the court and paperwork process of that as well. And then planning for the future. So I just like to make it clear that we are not a full scope estate planning office. We do presentations on advanced healthcare directives. They're a document everyone should have, like anyone 18 and over should have it in place. So we talk about that and how to fill it out and how to make decisions about what you want to put in there. Oops, sorry, I didn't mean to escape from that. And so when a client comes in as an elder abuse case or a guardianship case, we may help them with that kind of document, but it's not something that someone can just walk in and get help with. So I just like to make that clear. But we do the presentation, and I can explain how to fill them out and how to make them a legal document. We have a health law department. The words there say Medicare and Medi-Cal. You don't have to have Medi-Cal to use our services. So Medicare is really the foot in the door. If someone does have Medicare and Medi-Cal, we can help them with any of their questions or problems, but they might also have Medicare and a supplement, or Medicare and they're in a Medicare Advantage plan. So it really doesn't matter how someone's doing their Medicare. As long as Medicare is involved, they can come to us for help. The last department there is housing. It's a small department. It's very case by case. If you have any questions, the best thing to do is call our office to see if we can help. If we cannot help, then we try to refer to an appropriate agency that can. And right now, our staff is able to help tenants with issues, but not landlords. We just don't have the capacity to help in those areas. Okay, that's all the legal stuff. So the HICAP program is Medicare counseling. It is objective. We don't sell insurance products. Our job is to know everything about Medicare and how it works with anything else and be able to explain that. So that is what the counselors will help with. We are funded by the area agency on aging to run that program. We do, our counselors go through extensive Medicare training and then do continuing education year round to stay up to date. They're very knowledgeable. We offer counseling all throughout the county. Prior to COVID, we were at more than 30 locations in person. We have not fully returned in person to all 30, but we are in person at sites throughout the county, and we still are offering phone counseling. So we can do both or either. Some counselors are able to do video if someone wants that. You just have to call and make an appointment. These presentations are to help you know your rights and your options. And if the counselor is finding that it's a difficult case that needs to be elevated, they can refer it to our health law department to help take the case. All services are free. I will continue to say it again and again. So we can transition into talking about Medicare, which is federal government insurance designed for people who are 65 and older. Some people do qualify under 65 based on disability. There are no financial eligibility requirements, meaning they will not ask you about your income or your assets. They will simply, you're eligible to enroll when you turn 65 or possibly younger, and we'll talk about that on the next slide. So some of the rules for eligibility: you do need to be a US citizen or legal permanent resident who's been here for 5 continuous years. You need to be 65 or older, or receiving Social Security disability income for at least 24 months. If you are under 65 and receiving that, you will automatically be enrolled at month 25. If you are diagnosed with kidney failure or Lou Gehrig's disease, you don't have to wait 24 months. You basically get fast-tracked into Medicare. And so we definitely say that if someone's in one of those situations, that's a great reason to call for a HICAP appointment and get some help figuring out eligibility and enrollment and next steps. You do apply through Social Security. So HICAP doesn't process applications for Medicare, but we can help people figure out their eligibility and their options, and we can advise on enrollment, but you still have to enroll through Social Security. All right, so there are 4 parts to Medicare. It's a little bit of alphabet soup. Part A is the hospital or inpatient care. B is the medical insurance or outpatient care. So what is the difference? Inpatient means you are going to be staying there, as in you go into the hospital. Maybe you're having surgery, you're very ill, something's happening where you're going to be you're going to be, under observation. People will be taking care of you. You want to be admitted, and we'll talk about some keywords in a few slides here. But anything where you're staying there, that's going to be under Part A. B is the outpatient. So let's say you go to a doctor visit or you go get some lab work done, right? You're not going to be staying there. You're going to have your appointment and move on with your day. That's what I mean when I say outpatient. Original Medicare was developed as Part A and Part B. People could go to the hospital, people could go see their doctor. Much later, Medicare went, well, they can go see their doctor, and if they're sick, they can get a prescription. But if they don't have the money when they get to the pharmacy, they're probably just not going to get their medications because there's no coverage. So in the early 2000s, they added Part D, drug coverage. So I did jump over C, but I promise we'll go back to it. So D covers prescriptions. Or when we talk about someone on original Medicare, most likely they're enrolled in A and B, and they've chosen a Part D drug plan to go with it. And they may also have a supplement. And we'll explain those things too. What a Part C Medicare Advantage plan does is it takes your A and your B, and in most cases also prescription coverage, and it rolls them into a package where you are joining a network. So you're agreeing that by joining that insurance company's network, you're going to see their doctor groups at whatever hospitals they're contracting with. And most likely they'll also be managing someone's prescriptions, and pharmacies that they can get them at and what's covered. So we'll go into more detail on those as well. As far as Part A, most people do qualify for free Part A, either by their own work history or a spouse or former spouse. It's 40 quarters, which is equivalent to about 10 years of full-time work. If someone works part-time, they'll hit certain income thresholds throughout the year. So they may earn 4 quarters a year. If they're working very part-time, they may not earn a full 4 quarters every year, but they can work to get those quarters over time. As long as someone has their 40 quarters, they've already paid into the system and they will not pay anything else for Part A. If someone's not automatically eligible for Part A, there are 2 tiers. If they have 30 to 39 quarters with Social Security, they can choose to buy Part A for $278 a month. If they have 29 or fewer quarters, they can choose to buy Part A, but it's $505 a month, which is expensive. And there's one program we'll talk about at the end that if someone does have to buy their Part A, and if their income is low and they qualify, that program will pay this for them. So I promise we will get to that at the end. Again, Part A covers your inpatient care. So if I only have original Medicare, I've enrolled in A, but I don't have a supplement, I don't qualify for Medi-Cal, right? I'm just enrolled in Medicare. There is a deductible. Next year, that deductible will be $1,632. I like examples, so we're going to use one to walk through this. If I only have original Medicare and I slip and fall and break my hip, I'm going to go into the hospital and pay that $1,600 deductible. And then Part A is going to kick in and they're going to pay for the rest of my hospital stay. I'll probably have surgery, be there a few days. That's all going to be under my Part A. And then likely someone will come to me and say, Jenny, you don't really need to be here in the hospital anymore. And I'll say, okay, but I'm really not ready to go home. Maybe there's some stairs. Maybe I'm not getting up and down really well yet. For whatever reason, it's not safe yet for me to go home. The next level will be skilled nursing. So they're going to move me out of the hospital and into skilled nursing, which is covered fully by Medicare for 20 days. If someone's in skilled nursing longer than 20 days, there's a daily copay that next year will be $204 a day, and that stays 21 through 100. If I am there longer than 100 days, Medicare will completely stop paying and I will be paying fully out of pocket. I just like to remind, this isn't a case where I have no other kind of insurance, just my Medicare. So in my example, let's say I'm at skilled nursing for 2 weeks. Then I'm ready to go home. I'm feeling okay. I'm getting up and down. I'm getting around. Since 2 weeks is less than 20 days, I will have paid $0 for skilled nursing, right? Because I already paid that hospital deductible. So my skilled nursing was covered. And now I'm home, but I still need, the physical therapist to come and work with me. And I'm not ready to hop in my car and drive to their office. So my doctor is going to prescribe home health. And that skilled care, that in this case, physical therapy, can be provided to me at home at no cost. It's fully covered under Part A, and that's for as long as I need it, as long as my doctor says I do. So even if I'm not improving, but I need it so that I don't decline, that could be a reason that my doctor says that I continue to need it at home. Medicare has to pay for it. So those all fall under Part A. Completely separate from a broken hip example is hospice. So, right, if someone is terminally ill and they enter hospice, that will be covered under their Part A as well, but separate from the example I was using. This looks like a lot of text. I don't want to scare you. It's just some of the rules for enrollment in Part B. So most people are going to qualify as they're turning 65. And if they're not working or not covered by a spouse's work insurance, that's when they're going to enroll in Medicare. They can do it within the 3 months prior to their birthday month, the birthday month, or the 3 months after. That's their initial enrollment period. If you enroll in any of the months before your birthday month, your coverage starts on the first of your birthday month, even if your birthday's later in the month. That's because insurance runs on a monthly basis. So if they enroll in their birthday month, it'll begin the month following. There used to be a rule where if you enrolled in those months after your birthday, it kind of delayed how long it took for your Medicare to start. That changed in January of 2023. So now if they enroll in month 5, 6, or 7, the coverage will begin the following month, no delay. So if someone is turning 65, but they're still working, right? They may not need to enroll in Medicare yet. Maybe they've got their work coverage. They're happy with that. They're going to keep working for a few more years. fine. When they decide to retire, or if they ever lose that work coverage for any other reason, they will qualify for a special enrollment period. That's because they had coverage during that time that was considered creditable by Medicare. So there's no penalty, they're fine. They can use their special enrollment period to enroll. If someone missed their initial enrollment period and they missed their special enrollment period, there's one time of year that Medicare is open for anyone to enroll in, and that is the general enrollment period. It's from January to March annually. That also had a rule change beginning in January this year, which was people used to have to wait till July for coverage to begin if they enrolled in that January to March window. Um, they no longer have to wait all those months. If they enroll in the general enrollment period, the coverage will now begin the month following their enrollment. So, right, if they enroll in January, it starts in February. If they enroll in March, it starts in April. No one's waiting until July anymore. So that was good news. Most Medicare beneficiaries pay a standard premium for their Part B, and that in 2024 is going to be $174 a month, $170.70. It was an almost $10 increase from last year. In original Medicare, without any other kind of supplement, there is a deductible of $240 under Part B, meaning any outpatient services I go get, I would pay that first $240 out of pocket before my Part B now kicks in. When Part B is paying, Medicare pays 80%. There's a 20% co-insurance. So if I go to the doctor and the doctor says, Jenny, this visit costs $100. Okay, they're going to bill my Medicare first. Medicare is going to say, yep, this was a necessary medical visit. Here's $80. The doctor's going to say, great, I got my 80 from Medicare. Jenny, you owe me 20. That's again, if I have no supplement, that's original Medicare. If someone earns a lot in their retirement, they will pay more monthly for their Medicare. It's called an IRMA. It's an income related adjustment. This is not what you made at the height of your career, right? This is in your retirement if you fall into one of these tiers, and there's a bracket for individuals and for couples. So you can see if someone does, they're going to pay a very different rate based on where they fall. If you have retired, so you're not currently making this, but they're looking 2 years back at your tax return, because you won't have filed your most recent tax return in January when premiums for each year begin. So they look 2 years back. If you have had a change in your income in that period of time, you do have a right to go to Medicare and say, hey, Medicare, I need you to look at my current income situation, not my 2 year ago income situation. And they can adjust it to the appropriate level for what you need to be paying. Part B covers all these different types of outpatient services. So your doctor visits, diagnostic tests, rehab services, durable medical equipment. That one's really important. If you need a walker or wheelchair or any other kind of durable medical equipment, your doctor can prescribe it for you and it'll be covered under Part B. Ambulance rides also fall under Part B. Mental health, which is considered equal to physical health, they pay it out at the same 80%. And outpatient physical, occupational, or speech therapy. If I go to my doctor's office for physical therapy, that's outpatient. I have a 20% coinsurance. If they come to my house, it's under Part A, I pay nothing. So if I do need those services, it's good to work with my primary doctor to say that I need them at home if that's possible, because then it'll fall under Part A. So aside from preventative benefits, which we'll talk about in a slide or two, anything that Medicare is going to pay for needs to be medically necessary and reasonable. As long as it is, Medicare will pay their 80%. There are some benefits that are coming in 2024. That includes plan is required to notify you if your provider is leaving the plan. They have to provide access to qualified doctors and specialists. So they have to give you notification. Lymphedema compression treatment items will now be covered under Part B. Telehealth is going to continue to be covered under Part B, although starting in 2025, you must be in an office or medical facility to get telehealth. Or yeah, if you're in a rural area, you'll have to, then you can qualify for telehealth. But other people may no longer qualify after that. So, but for all of next year, it will continue to be covered. As far as managing and treating chronic pain, next year, if someone has chronic pain that is going to last more than 3 months, they're entitled to covered services under their Part B to work with that chronic pain management. And healthcare, they're opening up the types of providers that will be allowed to provide mental health services under Medicare. It's been very tight and very limited for a number of years, and they're going to make it a little bit easier for people to get help and see providers by opening that up to different levels of licensed providers, but just more kinds of providers will be allowed. So preventative benefits are fully covered, meaning you don't pay anything when you get these preventative benefits. They include a welcome to Medicare visit, your annual visit, lots of cancer screenings, diabetes screening, also smoking cessation, and vaccinations that are considered preventative, which include flu, pneumonia, Hep C if someone's considered high risk. The COVID vaccine has been added to that. And most recently, this year, they added shingles, which is a big deal because it's a very expensive shot. It did not used to be covered. Now it's considered preventative, so you can get it and pay nothing. They are adding RSV vaccine for that. And then COVID is now officially listed under preventative and included vaccines, although it has been covered the entire time. It will now be in the rules. There were also some benefits we just left out there that were added in the last 2 years, which include not only the shingles vaccine, but the tetanus, diphtheria, whooping cough, or known Tdap. Anything that the Advisory Committee on Immunization Practices considers preventative is going to be covered under Part B as preventative at no cost. Back in 2022, they also added bariatric surgery, cognitive assessment and care planning, blood-based biomarker tests, all COVID services, and additional opioid risk assessment. So if you need any of those services, you want to talk to your primary care doctor about getting your preventative benefits. This is my least favorite slide. I think I got like really wound up and was talking quickly. I'll slow down. These are the things that are not covered by Medicare. If it were up to me, I would give many of them to you. But I have to tell you that original Medicare does not cover routine dental. And we say routine and we mean basically anything. Like they're not covering cleanings, they're not covering root canals, they're not covering crowns. If you are if you need surgery and you have an infection in a tooth and you can't have that infection going into surgery, they might cover pulling that tooth and treating the infection so you can have that necessary medical right procedure. But those are very limited cases, and you really have to work with your provider to get Medicare to cover something like that. It's not impossible, but basically driving home the point here that anything routine is not going to be covered. Same applies for vision, and original Medicare does not cover glasses or contacts, routine hearing care. They're not going to cover hearing aids, and routine foot care. So all of those things are excluded from original Medicare. They also don't cover cosmetic surgery, any kind of experimental procedure, or any personal care at home or in a nursing home. So things that are considered long-term care won't be covered. You do have a right to appeal both your A and B if you disagree with a decision from Medicare. So if they say they're not covering something, you can go through these different levels if you need to continue, and I'll explain the levels here. But if a service or item is not covered and you think it was supposed to be covered by Medicare, if payment for a service or item is denied and you think it's something that should have been covered by Medicare, or if you're questioning the amount that Medicare paid for a service, you can appeal those things. They do need to be medically necessary to be covered by Medicare at all. They can't be one of the exclusions we just talked about. So you have your initial decision from Medicare, but you get it and you say, this doesn't look right, I disagree with it. You can ask for redetermination by Medicare. You're basically saying, hey, Medicare, can you take a second look at this? If they agree with themselves and say, yeah, no, we still don't think that was covered, the next level you go to is reconsideration by an independent contractor. So you're saying, okay, someone outside of Medicare, I would like you to look at this, compare it to the Medicare rules, and say whether or not this should be covered. A lot of people are going to win at that level. So usually when you ask Medicare or a plan, like we're going to talk about, to make a reconsideration on itself, often they're going to agree with their initial decision, unless someone really made like a gross error and overlooked something. So that's why it's really good to push through to the next level, because a lot of the wins happen in these higher levels. And that can be the outside person looking at it. If that doesn't work, the next level is hearing by administrative law judge. They're going to look over the rules. They're going to look over what you're asking for, the amount, all kinds of things, and they'll make a decision. If they do not decide in your favor, but you would like to continue on, you can apply to have the Medicare Appeals Council review it. And if they don't decide in your favor and you'd like to continue to pursue it, the highest level you can go to is a lawsuit in federal district court saying, Medicare should be covering this. If you are going to go through these different levels, you have to pay attention to deadlines and the amount that you're disputing, because that will determine your ability to continue on through these stages. Whenever you get a denial for something, it's going to have information on how to appeal to the next level, what your timeline is, and what the amount has to be to continue to move on. So if you ever need help with those things, please come make a HICAP counseling appointment. Our counselor will review it. They may refer you to the health law department to take the case. Yes, I'm sorry. I feel like I'm talking really fast. So thank you for pointing that out. Okay. We're going to move from Part A and B, which is original Medicare, to Part D to talk about drug coverage. And then just like we did in the little overview, we'll go back to Part C in a moment. So Part D drug plans are sold by insurance companies who contract with Medicare to be able to offer plans. These are offered statewide. So in California, next year, we will have 23 standalone plans. 3 of those are considered benchmark. Benchmark, if someone qualifies for Medi-Cal or if someone's receiving the extra help program, which we'll talk about in about 2 slides, they'll automatically get enrolled into a benchmark plan at no cost to them, but they don't necessarily check your medications against the plan they're enrolling you in. So it's really important to review which plan best matches your medication needs. I'm going to just jump down to the bottom point there, which is Medicare.gov has a tool called Plan Finder. You can do it on your own if you're comfortable going on Medicare.gov and doing it. A HICAP counselor can also do it for you. All you have to do is call and make an appointment. The counselor will ask about what you take, what medications, how often, and the quantity when you take it. I like to describe it as computer science magic happens, and it spits out a list of those 23 plans. What plans cover your medications, at what cost, and with what pharmacy network. There's a note here that the Inflation Reduction Act did cap the cost of insulin at $35 a month, and that started this year. It does have to be an insulin that is on the list of medications covered by your plan. So as long as you're taking an insulin that's covered on your plan, it'll be capped at $35 a month. If you have to take a different kind of insulin, it might be a good idea to review the insulin that you'd like to take, what plans that are listed on their formulary so that are going to cover that insulin, because that might be a reason you want to change a plan. So each plan sets up its own premium, meaning the amount you pay every month just to have the plan, the coinsurance, which you pay when you get your medication, and the formulary, that list of drugs that are covered under that plan. They do have to offer at least 2 choices in each drug category, and they have different pricing tiers. So, a blood pressure medication is probably going to be a lot more basic and covered under a tier 1. Cancer treatment medication is going to be a little more expensive, covered under tier 3 because it's a very serious medication. The plans all set their own pharmacy networks, and you do have a right to appeal if you suddenly need to start taking something that is not covered by your plan. The way that works is you go to the plan, you've figured out with your provider that you need this other specific medication, maybe because your body doesn't respond to the generic one that is covered by your plan. So you need this other one. So you go to your plan, you present this information that you and your doctor have come up with, and you can say, hey, plan, can you cover this medication for me for the rest of the year as if it was on the list, and I'll just pay my regular copay? And your plan will look over all that information, and they might say, hey, Jenny, yeah, we looked it over, and for you, we are going to go ahead and cover this as if it were on the list, and you'll just pay your regular copay. Or they might say, well, we don't think you've tried enough things yet, and we're not ready to cover that for you. We want you to do these other things. And so if they agree, it would be just for me, right? Not everyone who suddenly needs that medication or wants that medication would have access to it. It is a case by case thing. We can help with that as well in our health law department. If someone does have to do a drug exception request, please call us for help, because it's a lot to have to manage and worry about it, especially if you're already not feeling well and you really need a medication. We are here to help with that. We're currently in open enrollment. It goes through December 7th. As long as someone enrolls in a plan by 11:59 on December 7th, it will take effect on January 1st. You enroll at medicare.gov or by calling the company directly that's selling the plan that you want to join. If you don't have creditable coverage, and this is a Medicare word, creditable coverage, it means that they think that your drug coverage is at least as good as the requirement that a plan would have to be a Medicare plan. If you don't have coverage that's equal to that, you could have a penalty when you go to get a drug plan. So the best thing to do is, let's say you're still working and you're covered by your employer, you just want to check with your HR or your benefits department to make sure that the medication portion of your insurance is considered creditable by Medicare. As long as it is, you won't have a penalty. But if it's not, you might want to look at your options for enrolling in Medicare sooner. Or like there's other things, like the VA is considered creditable. So that's not necessarily that someone has to be working. But as long as they're getting their medication in that setting, it's considered creditable. There's no penalty. So if you do have a penalty, it's a weird formula. It is 1% of the national average premium. Next year, for all drug plans across the nation, the average cost is $34.70. So it's 1% of that times the number of months that you were eligible but did not enroll in a Part D plan. I like examples. Let's say I turn 65 and I'm not taking any medication. So I think, why would I join a drug plan? I don't want to pay a premium for something I'm not using. Okay, so I wait a while. It's 5 years later, go do my, annual checkup with my doctor. I'm 70, I'm feeling like, all right, like, how are we doing? And the doctor says, Jenny, your blood pressure's a little high. I'm going to put you on some medication. Okay, I'm ready to go get a drug plan because now I have a reason to take a medication. What I'm going to find out is that when I go to enroll in that plan, I was eligible but did not enroll for 5 years. That's 12 months per year. It's 1% per month. So that's 60%, right? 5 years times 12 months. I now have a 60% penalty. That's 60% of $34, which is roughly $20. We're going to just keep it at a flat number because mathematically it'll be easier. You can check my math if you want. I'm pretty darn close. So when I go to enroll in a plan at the age of 70, I might choose an average cost plan. Maybe I'm choosing a $34 plan, but it's not going to cost me $34 every month. It's going to cost me $54 because I'm going to pay my plan premium every month plus my 60% penalty. And I'm going to have that penalty for the rest of my life. So if anyone has a question about penalties, about drug plans, please call for a HICAP appointment. This is a really confusing slide. Also has a lot of information. What it's trying to do is walk through the tiers that happen in a drug plan. So this is the minimum a plan has to meet to be a Medicare plan, meaning next year their deductible cannot be more than $545. It could be less. You could join a plan that has no deductible or a lower deductible, but no Medicare plan can have one that's more than $545. So when a person starts their plan at the beginning of the year, if there's a deductible, they're going to meet that deductible. Then they'll move into their initial coverage period. In that period, the plan pays 75%. You have a coinsurance of 25%. That's determined based on contracts between your plan and the drug makers and all those things. But when you go to the pharmacy, you're paying 25% as your copay. If someone has drug costs that get higher and move in through the year, they're going to move from their initial coverage period to their former coverage gap. It's no longer a coverage gap. There is coverage now in that period, but it used to be called the donut hole, because in this period, your drug plan just stopped paying. They were like, nah, your drugs got expensive. You can pay for them for a while, and maybe we'll pay again later. So with the Affordable Care Act, this closed over the years from 2010 to 2020. So for a few years now, it's been consistent, so that if someone moves from initial to that coverage gap, they're really not seeing a difference in cost, except for that a pharmacy can charge a dispensing fee. So there might be an adjustment, but there should not be a giant change in cost. If someone sees a giant change as they switch from one level to another, please call us for help. The difference for next year is that if your drug costs get high enough to be in the catastrophic benefit period, then there will be 0% that the person has to pay. They'll move into catastrophic coverage and be 100% covered. So that's new, because it's always been 95%. There used to be a 5% coinsurance. That's going away. It will be 100% covered if someone hits the level of catastrophic. People who don't take a lot of medications are never going to get anywhere near that period. But someone who's on a lot of medications, or very, serious medications, they may hit that catastrophic period early in the year. If that happens, right, then they will not continue to pay anymore. And that goes all the way from January through December. It cycles on a calendar year. Okay, here's the program I mentioned called Extra Help. It is also known as the low income subsidy. If an individual has an income of $1,823 or less, if it's a couple, it's $2,466 is the cap. And then the assets for an individual are $16,660, and for a couple, it's $33,240. So it about doubles for that second person. If they fall into those income and asset limits, they will qualify for Extra Help, which is a program that helps pay their premiums, their deductibles, and copays. I just want to touch on assets. When I say assets, they're not counting one home. If you have a second home, they'll count the value of a second home, but they're not counting one home or one car. So those are not counted. They're not looking at your jewelry or your computer or stuff in your house. They're really looking at money in the bank. So this is what we're talking about when we're talking about qualifying for these programs. So if someone qualifies for this, they're going to have those costs covered. They would be put into a benchmark plan at 0 cost to them. But again, you might want to run that plan finder to make sure that you're in the correct one that covers your medications. There's no gap or donut hole that they ever have to worry about, no change in costs. And they get an extra benefit where they can change their plan once per quarter in the first 9 months of the year. So I told you you could do an exception request. Everyone has a right to do an exception request. If I have Extra Help and my doctor puts me on something new during the year, I don't necessarily have to do an exception request. I can just go back to the plan finder and look for a plan that covers everything I'm currently on plus the new medication, and see if it makes sense to change plans. You apply for Extra Help through Social Security. This is something that our counselors can help someone apply for. So if they want help applying for Extra Help, we can help with that. There was a lot of help in that sentence. I do see a few questions coming in. I will pause in about 2 slides and look at the Q&A. And just, I know I recognize I've been talking at you for a very long time, so I appreciate you staying with me. So there are some appeal rights under Part D. If you show up and your pharmacist tells you that the drug you're taking is not currently on the list covered by your plan, unfortunately, plans can drop things during the year, even though you've already enrolled in the plan for the calendar year. So if there's a change there, you can appeal. If it's a drug that is not on the formulary, but it was prescribed by your provider and is medically necessary, you can appeal. If the copayment changes, or you can't afford the new amount you're being required to pay, you can appeal. And if you're asking the plan to cover a non-preferred drug at a preferred drug cost, that's a reason you can appeal. If any of that happens, you do have a right to request coverage determination or an exception from your plan. The way that this will happen with the plan is that there are the same 5 levels. Redetermination will happen within the plan that you're in, right? You're basically saying, can you take a second look? If they decide to agree with themselves and you're like, I'd like this to go further, you can go to that reconsideration from the independent review entity. That's the outsider saying, okay, can you look at the rules and see if this makes sense for them to cover this? If that person agrees with the plan, but you'd like to continue, you can go to the administrative law judge level again. After that, it would be the Medicare Appeals Council. And finally, the last level is federal court. And the same thing, you do want to pay attention to timelines and cost. So before we get into the ways to supplement Medicare, let me see. There's a note that says IRMA. Yes, the income related monthly adjusted amount, which is where you have to pay more. Does retirement count as a life-changing event that would be approved to or by Medicare to lower the amount you'll pay? So basically, yeah, if your income changes because you've retired, yes. And because they're looking at 2 years ago. So we're going into 2024. So they're not looking at your 2023 tax return, they're looking at your 2022. If you were working then and anything has changed, and you at sometime in 2023, your income changed, you have a right to fill out a form that says, hey, Medicare, this is my current income situation, and I would like to pay my Part B and D premiums based on my current, not my 2022. If you need help with that, it's also a great reason to talk to a HICAP counselor who can help you with that form, or you can do it independently with Medicare if you don't feel like you need help from a counselor.
So Jenny, I have a question about
Yes.
with regard to that form. How do we access that? Do we just go on the Medicare.gov and put in their search engine the appeals form for changing IRMA, or is
Yes. If
okay.
I were going to pick a couple keywords and not have a super long sentence, I would go to Medicare.gov, and in the little search engine, I would put IRMA appeals. And it should lead them to the form. If it's not, if you're getting frustrated, call us and we'll help.
Okay, and so just to continue on with that for a second, because I've tried to help somebody with this particular situation, and the form we get basically says you need to go to the Social Security office. Is that accurate, or is this something that could be handled online, or as you mentioned, with help from a HICAP counselor?
So I think the counselor can help fill out the form. If I'm correct, it probably still has to be turned in at Social Security or mailed to, but I don't think that you can do it online. I think you do have to have a physical form that gets filled out that you sign and either submit in person or mail to Social Security.
Okay.
Mailing is always questionable. I would say it's better if you can submit it
Yeah.
in person.
And the other thing is, what I've noticed is that that Social Security and Medicare, in determining the IRMA, look at your tax returns. So let's say that your income for last year or the year before has, decreased for whatever, life-changing event was.
Yeah.
Will they automatically adjust that? And do they do that every year? Or is, again, that's something you really need to keep an eye on and file that appeal?
So they won't necessarily automatically do it because they are basing it on your tax return from 2 years ago. And so, like, let's say, okay, the new year has started and you file your taxes. They're not going to look in like April to see, oh, did their taxes change? Should we lower it? That you really want to fill out the form and send it to them. And even if you do it a little bit later into the year, as long as you can show that at the start of the year, that was reflective of your income, um, they'll adjust like the overpayments that you have then made and credit that toward.
Okay.
Yeah.
Okay, good.
So it's not like you are losing out by waiting a little bit, but definitely you want to fill that out as soon as you realize that you have the option to do so.
Okay. And then also I'm going to throw another question in here only because it was from this first portion. So you mentioned that Medicare is covering some new preventative types of things. And on that list, you had cognitive assessment and care plan. So I know in the annual wellness visit, doctors are essentially required, even though they don't always do this, is to do just a quick little, cognitive screening. But what caught my attention was a care plan. So do you know what that involves or what that includes?
Um, I know that it's in there as a preventative benefit, so they're, required to provide it. If in some instances, if you don't ask for something, even though it's required to be covered, you may not get it because they're not necessarily saying, oh, here's everything you qualify for. Do you want something on this list? So it's good to go in knowing that you have a right for that, and to ask for it. I think advocating for ourselves is always really important, or if we can have someone who can advocate on our behalf, who can go in and say, oh, I know that this is covered. What are we going to do under that coverage? That's a good way of making sure they're getting what they're entitled to. And to what extent they're helping with the care plan, I cannot answer because it could vary from provider to provider or insurance company to insurance company. It's required to be covered, but I don't know what the very specific details are in that coverage. And that would be something that the provider would have to work with the patient to sort out.
Okay. Yeah, because care plan or care planning is really vague.
Yes, it is.
And
I
we
agree with
don't,
you.
yeah, and we don't have resources in our communities that actually can, and the doctor certainly can't do that based on my experience with that. So I'm going to do some more digging
Yeah.
on that one because I think
I have a
it's important.
feeling, if I know anything about insurance, and I know some stuff, I have a feeling that they might do the cognitive assessment and they may pass the care planning on to a medical social worker or someone else who falls within the insurance cover, someone who's covered under that insurance level, but it may not be the provider who's helping with that next step. It might be. I'm sure it depends a lot on your provider and their practice and all kinds of things, but they may be passing that to someone else within the network.
Okay.
But it's
All
covered.
right. It's covered, but yeah.
Yeah,
Okay. I know that's so nebulous, but thank you so much.
you're welcome. I'm sorry I can't be more detailed.
No, as I said, that's one of anyway. That's our healthcare system.
Yeah. Part D question did come in, and it's a really great question, which is, if you're eventually going to get penalized for not having Part D, why would you opt out of it? So, and the rest was, assuming as we get older, we would need to take medication. It's a great assumption, and not everybody knows there's going to be a penalty. So if in my example, I just didn't know at 65 that I was going to have a penalty later, I waited all those years because I thought, well, I'm not using it. The thing with insurance is that a lot of the model is built on people who may not be sick in that moment paying into a system so that when the people who are sick need something, there's that pot of money that gets pulled from. And so that's why the system wants you paying in, even if you don't need any medication. But if someone isn't aware of the penalty or why the system works that way, they may not choose to get a drug plan at that time. I mean, there are other things that can happen too, but yes, we want to make sure people at least know that that penalty could exist if they don't have it, and trying to figure out creditable coverage. So yeah, it's a complicated system, and most of us probably will need it more as we get older, and it's a good idea to join it when we're eligible, but sometimes things happen and we don't do that. All right, I am going to transition into supplements, but if anything pops into your head related to stuff we've already covered, we can always come back and answer those questions as well. Feel free to put them in the chat. So we're not going to go through each type of supplement today, but I'm going to give you this quick overview and then we'll do more detail on about half of them. We will talk about Medigap plans, which are a way to supplement original Medicare. We're going to talk a lot about Medicare Advantage plans because it's the time of year when those Part C plans are doing their open enrollment. There are plans sometimes from employers that work with a person's Medicare. Sometimes it's retiree coverage that works with a person's Medicare. Today, we won't spend time on those. If you have questions about any of that, it is something a counselor can help with. TRICARE is for people who've retired from military service. So people who did like career military and retire will qualify for TRICARE. It's a great supplement to Medicare, works really well. If anyone has questions, again, please make an appointment. The VA, it's a little silly because the VA is actually not really a supplement to Medicare. It really is its own system and they do not talk to each other. But we like to mention that if someone qualifies to use services at the VA, they can get their services at the VA. The VA will not bill Medicare for anything. Everything will be covered under their service connection. Sometimes they have copays, depending on their service connection, they may not. But if they're eligible for those things, they can get them at the VA. The VA is creditable coverage according to Medicare. If someone goes outside of the VA for something, it's very unlikely that the VA will pay for that outside care. There are some cases where if the VA can't provide care, they may pay for care outside the VA, But basically, if someone has Medicare and they get services outside the VA is going to say, okay, that's covered under your Medicare. We don't touch that. So that's about as far as we'll go into VA benefits today. But if you have questions, of course, call us. And then we will cover Medi-Cal and Medicare Savings Program at the end. So let's start with the Medigaps. I kept talking about original Medicare, or what we also can call fee-for-service Medicare. You go, you get some sort of treatment or service, your provider bills Medicare, and then you may have a copay or co-insurance. If you have a supplement, Medicare will be billed first, then the supplement will be billed. And if there's something that the supplement didn't cover, you may be billed for that thing. But depending on how comprehensive your supplement is, it may just be that Medicare pays, your supplement pays, and really you don't ever see bills. So that is what a Medigap can do. There are 11 different policies that are Medigap policies. They also use letters, and the letters of the Medigap have nothing to do with the part of Medicare that they cover. They're just also letters. And so the most basic Medigap is an A. It's going to cover the least amount of services. It's going to cover really basic stuff. It's also going to have the lower premiums than something that's really comprehensive and has a higher premium. So the really comprehensive plans, right, are going to cover a lot of things. Pretty much you're going to go get services and like I said, not really see bills because Medicare will pay, the Medigap will pay, and you're just paying your monthly upfront premium to have the Medigap. The plans are standardized, and what that means is it does not matter what insurance company you buy the letter from. Any insurance company that's selling that letter of Medigap covers the same things. So it's either gonna, be really basic, really comprehensive, or somewhere in the middle, but they cover the same things under each letter. We do have a comparison chart to show what kinds of things are covered by the different letter Medigaps. And then also it's got a price comparison. It's really a snapshot. So you do still need to contact the Medigap companies to ask them what their premiums are. But we do have a chart that we put out that's a good snapshot in time of like what for a typical age range to get a typical policy under that letter from that insurance company, what they charge. So standardized. You can buy it from any company. Some will charge more, some will charge less. The coverage is the same. The policies pay after Medicare pays. So as long as Medicare can pay its portion, then the Medigap will pay something that falls under its coverage. There are no network restrictions. Basically, if you have a provider who accepts Medicare, then you can go see any provider. Medicare will be billed first, the Medigap will be billed second. It'll fill in those gaps, the co-insurances, the deductibles. There is a guarantee issue period when someone is new to Part B. They have 6 months. They can sign up for any letter Medigap they want from any company they want it from, and the company has to take them. If someone is not in a guarantee issue period, they may have to go through health underwriting, meaning the company is going to ask them questions about their health history. They may do some blood tests. They may do some other, questionnaires or things that they're going to ask them. And then the insurance company will review all of that information. And they'll say either, sure, we're going to cover you under this policy, or you look kind of expensive and we don't really want to cover you. And unfortunately, they're allowed to say that if someone is not in a guarantee issue period. So some insurance will offer these underwriting holidays. That's the term that they use, meaning even if you're not in a guarantee issue period, you may be able to go to that company and ask them to cover you under a certain letter. And if they're in an underwriting holiday, they'll just sell you the plan. They won't ask you all those health questions. Any insurance company that wants to offer any Medigap has to offer at least the A, and then from there they can choose which other letters they want to cover. So not every insurance company covers every Medigap letter, but you can shop around. And if you have questions, and I know you've heard me say it 20 times already, call a counselor can help with these kinds of things. They'll help you figure out what you're looking at, how to read those charts, and if you need help, they can help you sort out like who to call to find out. A lot of times we know if there is an underwriting holiday for a particular company, so we'll help with that. So I want people to think of the original Medicare path with the supplement as one road that they could go down. They could have the A, B, get their drug coverage, and maybe a supplement so they're not getting surprise co-insurances or bills from things. The other path is the Medicare Advantage plans. This is where an insurance company contracts with Medicare. It's on an annual basis. So that's why we have open enrollment for these every year, because they can change from year to year. What the insurance company does is they go to Medicare and they say, okay, Medicare, for every person that joins our plan, we want you to pay us X amount of dollars. It doesn't matter if that person needs tons of services or no services. Maybe that person never comes through the door. You're going to pay us just because they joined our plan. Medicare is like, great, that's a fixed cost. We're not getting surprise hip surgery bills. Like, sure, we're going to pay you for every person that joins your plan. The insurance company is like, great, that's guaranteed income, right? We know that by having people enroll with us, Medicare is paying us. So they look at each other like, this is a good system. For some people, this is a good system. For some people, original Medicare is a good system. But we're going to make sure you know what your options are. And so in this case, if a person joins the Medicare Advantage plan, they're in the network of doctors and hospitals that are in that group. They're going to go there for their services. The plan is going to coordinate all of that for its members. And the cost to join a plan and the different copays and things can vary from county to county. So what I will be talking about today is specifically the plans that are available in Alameda County. If someone is outside of Alameda County and has questions, I will show the 800 number at the end, which routes anyone to their local California HICAP. So each county is served by its own HICAP. Some in the rural areas cover multiple counties, but they know based on your county what you're eligible for. They can answer any of those questions. And as Debbie mentioned, like even outside of California, a lot of places call it their state health insurance program, but it's the same Medicare counseling that's available anywhere where there are Medicare beneficiaries. So you can compare these Part C plans, just like you compare the drug plans, using the Plan Finder tool at medicare.gov. We can also help someone if they have questions and they want us to help with that. It is currently open enrollment through December 7th. You will start the year in your plan if you join an MA plan. If you start the year in your plan and you figure out very quickly, this was not the plan for me and I need to get out of it, there is a Medicare Advantage open enrollment period from January through March 31st, where a person can get out of the plan that they joined and go to any other Medicare Advantage plan available in the county, or go back to original Medicare. If they're going back to original Medicare, they may not have a guarantee issue period for a supplement, so they really want to think about some of their options. Also a great reason to talk to a counselor. Most people, if they're going to change their plan, really only do it once a year, but you do have these rights to make changes if you need to. You enroll in a Medicare Advantage plan, either through medicare.gov or with the insurance company that is selling the plan that you want. You do have to be enrolled in A and B if you want to join Part C. So there might be a case where someone has only enrolled in A and not B, or they've only enrolled in B, but they had to pay for Part A, so they didn't enroll in Part A. If a person is in that situation, they will not be eligible to join a Part C plan. They would need to use the general enrollment period to enroll in whatever part they're missing, and then later would become eligible to enroll in a Part C plan. If someone has end-stage renal disease or kidney failure, they did not used to be able to join a Medicare Advantage plan. Back in 2021, that rule changed. So anyone can join a Medicare Part C plan as long as they have A and B. And many of the plans do include drug coverage. In Alameda County, we have three kinds of plans. We have HMOs, which are a more restrictive network, PPOs, which are a network, but a little more freedom, and special needs plans, which look at people's conditions or qualifications. So I will talk about those. I also feel like I'm getting excited and talking fast again, so I'm going to try and slow myself down. So what this shows is that there's an insurance company that sells a plan. In many cases, they sell more than one plan. Aetna has 7 plans listed here. Yeah, 7. They'll tell you, is there a premium to join that plan? Most of their plans have no premium. Remember that they want you to join because Medicare is going to pay them just for your joining. So they're like, okay, we're going to be very attractive, no premium. They're also going to throw other benefits your way. They might say, we're going to cover glasses every year. We'll cover a portion of a hearing aid. We'll cover your gym membership. There's all kinds of things that they're going to offer. But what's really important is if you like your providers, if you like your doctors and you don't want to have to change doctors, you really want to look at, for any of these plans, what doctor groups they contract with and what hospitals they work with. More important is the doctor group, because if your doctor is in a group and you switch it to a plan that doesn't have them, you're going to have to change providers. If you're not sure what doctor group your provider is in, give them a call. Their office should be able to tell you. So is there a premium? That's listed here. You see these ones with very patriotic names like Eagle and Eagle Plus. They don't have drug coverage. They're assuming that people joining those have other access to medication, probably from the VA. There's a few other plans that have no coverage, no drug coverage built in, and you can see they also have very similar kinds of names. Alignment is selling a few plans, Anthem is selling a few plans, and so you go through these. As what I want to point out on this slide is that there's two that are in kind of a green color, if you can tell, and they have a price and a zero. These plans are $0 if the person qualifies for Medi-Cal. They can join this plan, pay no premium, no co-pays, all of that. If the person does not have Medi-Cal and they join one of these two green plans, they are going to pay that monthly premium. And it gets called a mirror or a lookalike plan because the cost sharing mirrors original Medicare. A lot of 20% co-insurances, lots of deductibles that match the Medicare deductibles. So really, there's not a lot of extra benefit to joining one of these plans if you don't have Medi-Cal. However, we won't tell you ever what you should or should not join. But if you look at this, a lot of the cost sharing seems pretty high. So it may not make sense to join that plan if you don't have Medi-Cal. Here's page 2 of HMOs and PPOs. So again, tells you the insurance company name, if there's a premium, and there's one more lookalike plan on this one. There's one more that had no drug coverage. So you can really see some of the details here, but this is not meant to be nearly as comprehensive as our chart that we put together. And I sent the charts over to Debbie, so those will get shared. There's a chart that compares all the HMOs. There's a separate chart that compares the PPOs. And then there's a third chart for special needs plans, which we'll talk about in a second. When you look at these charts, it's a lot of information. It can look overwhelming, but what you really want to look at is at the top, it tells you insurance company name, then it'll tell you different plan name. Side by side, it's going to compare not only does it have a premium, but what does it cost to see your primary? What does it cost to see the specialist, to go to the emergency room, to take an ambulance ride? All these are laid out side by side, so you can really look at more of the details of these plans. Most importantly, at the very bottom of the chart for every single plan, it's going to tell you what doctor group and hospitals they work with. So that again is something you really want to look at if you like your providers and you don't want to change. Special needs plans are a little bit different. There are 3 kinds that we have. C is for chronic, D is for dual, meaning they qualify for Medicare and Medi-Cal, and I is for institutional, someone living in long-term care. So on this chart, and there's another, again, there's 2 pages of this. On this chart, it tells you the insurance company name, and then it tells you what kind of special needs plan they're selling. So that first example is Aetna, it's a D-SNP. That means it's for duals, meaning there's no premium and there's going to be no co-pays or anything, as the person does have to have Medicare and Medi-Cal to join. If you look down to the next one, Align Senior Care is selling C-SNPs and I-SNPs. C, memory care for dementia. So that plan, if someone has a diagnosis of dementia, is going to work with them around that diagnosis and providing care. Their other C-SNP is for people with end-stage renal disease. They have 2 institutional ones. If you look through some of the other C-SNPs, you'll see conditions like diabetes, heart disease, cardiovascular disease. So if the person already has these diagnoses and they want to join a chronic special needs plan, they can. Again, look at the doctor network on the chart to see if it makes sense for a person to join one of these plans or if they're willing to change providers, and look at what other coverage and benefits it's going to offer. So these are really important to look at on the chart if you're considering these, because these charts give you a lot of information. There are a few more companies that are selling C-SNPs and D-SNPs. We also in the county have PACE plans. They are like special needs plans. The person does have to be 55 or older and at risk of institutionalization. So these plans provide a lot of extra services like rides to their appointments and the day center where they have other activities and more wraparound type care services that they're going to make sure that the person's getting if they need them. Currently in Alameda County, if you live in the north or central part of the county, Center for Elder Independence is the PACE plan. If you're down in the Fremont or South County area, Unlock is the provider for PACE plans. Center for Elder Independence did recently break ground in the Tri-Valley area on a new center. I don't know what their completion date is going to be, but it is going to make it easier for people who are in the Tri-Valley to join a PACE plan if they would like to. The most important thing to know about the PACE plan is that they are their own network of providers. So while they do provide really great care and lots of extra services, you will have to give your your management of all your medical things over to the PACE plan and see their providers. I'm going to pause for just a second. I have not seen anything else come in. If you have questions, this is a great time to put them in. Otherwise, we're going to start talking about we'll talk about appeals, and then we'll talk about some of the Medi-Cal and Medicare savings programs. Okay, so you've given your care over to a Part C plan. You're in their network, right? You have to see their providers. Well, there is an appeals process. It's not that different from original Medicare. You do have a right to appeal. If your plan is denying payment for medical services that you got outside of your plan, maybe it was an emergency or urgent care, you can appeal that if they're trying to deny that coverage. If your plan refused to give you treatment in a timely manner, you can make appeals if you need to go outside and get care somewhere else. If your plan discontinues a service that you think is still medically necessary, you can appeal that decision and say, hey, I need you to keep covering this. And so if you have questions, of course, you can always call us. It's similar in those levels, meaning if you file an appeal and ask them to look at it, it's going to happen within the insurance company that the plan is with. They're going to make their own redeterminations. They're going to look at their own rules and say, do we agree with ourselves? Probably they will. Again, I really encourage people, if you're going to go through the appeals, to at least get to the outside entity level, because a lot of times it's hard to get within the plan or within the drug coverage to get them to disagree with themselves from their initial decision. But you really can get a lot of change at the next level. So you can have them redetermined within the plan. You can go to external review by the independent review entity. You can also then proceed to an administrative law judge, a board of appeals, and all the way up to federal court if you disagree. You do need to, again, pay attention to dollar amounts and time limits. All of that will be listed on paperwork every time you get a decision. And if that decision is not in your favor, then again, right, you can go to the next level. You are the one that has the power to proceed through these levels. So if you get a decision in your favor, that's it. It's a final decision. The insurance company can't push it up to the next level. Only you can push through these different levels. And that applies in drug plans, and in Part C. You are the one who moves things forward. Medi-Cal is California's version of Medicaid. It is for people who have low incomes and limited assets, but the asset restrictions are going to change very soon. It does pay for medically necessary care, and it is always the payer of last resort, meaning if you have Medicare and Medi-Cal, Medicare will always be the first payer as long as it's a Medicare covered service, right? Medicare will pay first. Then if there's something left to pay, it may be paid by Medi-Cal. I'll talk about that in a second. But in any case, you are not responsible for any portion left of the bill. Medicare pays first, Medi-Cal would pay second. If you have a supplement, like you have a Medigap and you keep that Medigap even though you've qualified for Medi-Cal, there are lots of reasons people do that. Medicare would pay first, the Medigap would pay second. And if there's something that wasn't covered in the Medigap coverage, Medi-Cal would then come in and pay. So payer of last resort always. Currently, the income limit for an individual to qualify for Medi-Cal is $1,696. For a couple, it is $2,288, right? So anything that or below, the person or couple will qualify for Medi-Cal. The asset limits currently are $130,000 for an individual and $195,000 for a couple. Not that long ago, and for a very long time, those limits were $2,000 for an individual and $3,000 for a couple. In July of 2022, they made a huge jump, allowing a lot more people to qualify for Medi-Cal. And starting in January, California is eliminating the asset limit for aged, blind, and disabled, right? So this is Medi-Cal for people who are either over 65 or blind or have a disability. If someone doesn't qualify that way, they're probably on Magi Medi-Cal. It's a little bit different system. We're talking about Medi-Cal that's going to be working with Medicare. They're eliminating their assets. The Magi Medi-Cal didn't have assets to start with. So now both programs will match. The income limits will match. The asset limits will be eliminated. So anyone who falls into the income qualifications to get Medi-Cal should apply for Medi-Cal because those asset limits are going away. There's also the Medicare Savings Program known as the Qualified Medicare Beneficiary Program. This is the one program that will pay a person's Part A premium if they have a Part A premium. This will pay their A and their B premium, their deductibles, and their any co-insurance that they have. It works a lot like Medi-Cal. The difference is that Medi-Cal actually doesn't pay a Part A premium. So if someone has a Part A, they really need to apply for this. There is an income limit of $1,235 for an individual and $1,644 for a couple. So you notice those are actually lower than the Medi-Cal ones. That's why if someone has a Part A, they really want to see if they're going to qualify for this, because they can definitely qualify for Medi-Cal if they meet those. But if they need that Part A paid, they really want to apply for this as well. The asset limits are also going away on this program beginning in January. If someone applies now, because we're in November. So if someone applies now, Medi-Cal will look at their income, and then if they have over the current asset limit, they will schedule them to begin January 1st. If they're under this current asset limit, they would start in December. Or you can actually retroactively apply for Medi-Cal as well if you check the right box. So if you need help with any of those things, you know who to call. So those are there are a couple other Medicare savings programs, but we're not using them on the slides anymore because the income limits for those programs are lower than the Medi-Cal one, and all they do is pay the Part B premium. So if someone would have qualified for those, they may as well just apply for Medi-Cal and get better coverage. This is the note I promised, a note on balanced billing. So if you have Medicare and Medi-Cal or Medicare and QMB, you are not allowed to be balanced billed. Remember way back when I said I could go to the provider and they say, Jenny, this doctor visit costs $100. Great, Medicare pays $80. If I have Medi-Cal, that $20 needs to be billed to Medi-Cal. What sometimes happens is that Medi-Cal has low reimbursement rates, and they say, well, provider, we would have only deemed this worth $70. Medicare already paid you $80. So as far as we see it, you've been paid in full and we're not giving you another $20. That's within the rules. That's what the provider accepts when they choose to accept Medi-Cal. That's just the way it is. What they're not allowed to do is come back to you and say, hey, they didn't give me $20. You have to give me $20. You are protected by your status of having Medi-Cal or QMB to not have to pay that balance, right? And that's just a simple example with the $100 doctor visit. I mean, it could be a much higher. In any case, it's not your responsibility to pay it. You are protected by the programs. So federal and state law says that they have to consider any payment received by Medicare or Medi-Cal as being paid in full, and they cannot bill you. There's no legal obligation to pay anything further. Do not ignore a bill. If they do try to bill you, you never want to just leave it sitting there, even though you know you don't have to pay it. You want to call their office. You want to say, hey, did you remember that I have Medi-Cal or I have QMB? And if you've billed them, then you're paid in full. And if you haven't, remember to go back and bill them because you can't bill me. They should work very easily with you to resolve that bill and make it go away. And if they don't, call us, because often when we're calling from HICAP or calling and saying, I'm from Legal Assistance for Seniors, it can move that little needle along. If you ignore it, it can end up in collections. So just don't ignore it. Let's deal with it if you do get a bill, but please know you don't need to pay it if you have Medi-Cal or QMB. Medicare is a huge system. Billions of dollars are spent in the Medicare system each year on care that's valid. It's also estimated that 10% of that budget is on waste, fraud, or abuse. 10% of billions is still billions that gets wasted. So we want to report any suspected fraud. You can do that. There's the federal task force. There's Senior Medicare Patrol. And I'm going to go to the next slide that has some resources. You can always call the 800 number that routes you to your local HICAP. That can get you started on reporting fraud. You could call Senior Medicare Patrol directly. They also work with the Office of the Inspector General. And so they really do investigate, and they do amazing fraud cases where they catch people who are doing bad things and make them pay money back into the system. If you're not sure where to start, you can always call 1-800-Medicare. They'll get you in touch with the right place as well. And you can call the Office of the Inspector General directly, or call the FTC ID theft hotline if you think that identity theft has occurred. We're almost done with the slides. If people have questions, you can start dropping them into the Q&A or the chat. And then we can also take them live here in a second. Couple more resources. Medicare.gov is a great resource, and you can call 1-800-Medicare with questions. This time of year, they'll usually tell you to call your local HICAP. The Department of Insurance has lots of information on things like Medicaps and long-term care insurance and all kinds of things that get regulated within the state. And the California Health Advocates produce tons of fact sheets. We use a lot of their fact sheets in our office. They can explain how Medicare works with literally anything, any other kind of insurance, Medicaps, employee coverage, retiree coverage, veteran coverage, all of it. There's a fact sheet for it. If you would like an appointment, you can call our office directly at 510-839-0393. That will route you to our HICAP scheduling line, where you can leave a message. And then one of the schedulers will call you back to set you up on a time with a counselor, and you can let them know if you want to be seen in person or over the phone. If you're not in Alameda County, you should call 800-434-0222 to get routed to your local HICAP office. Our website is listed there. And, you know, if you are like, wow, Medicare is so interesting, I love talking about insurance, you might be a great volunteer to become a counselor. And also, we do this presentation all throughout the county. So if you are part of any other group where you would like us to do a presentation, you can always contact our office and ask for that. Okay, that was it. I just talked to you a lot. I appreciate your listening ears. If there are questions, we can go ahead and take them.
Okay, let me chime in for just a little bit, maybe what people are possibly thinking of
Sure.
questions or typing in questions. First of all, I have to tell you, HICAP is like amazing. I refer people to HICAP all the time, both people that I deal with professionally as well as friends, family members. And I always get feedback from those individuals saying there are angels at HICAP. They have solved problems that nobody else was able to handle. So, you know, I do want to encourage you to use that amazing free resource. And a lot of the resources that Jenny has mentioned, I've also included links and phone number, or links primarily, on that resource list, my online resource list that goes along with this webinar. The other thing is there was just a ton of info today. And if you haven't already done so, all of these slides are also on our on the Hope Hospice website under archived classes or archived presentations. So you can get copies of all the slides, and the charts that Jenny mentioned are there. I was looking in my notes as you were talking, and I realized there's 3 charts that I neglected to upload. So I will take care of those in the next hour or so. And so everything will be up there. And then lastly, a recording of this webinar is going to be posted on, and I mentioned this earlier, it's going to be posted on our website, should be there by Monday morning. And I typically don't record the questions portion of this, just so that people can feel like, oh yeah, I don't want to be on YouTube with my questions. So if anybody does, you know, have any specific questions, I'm going to go ahead and stop the recording. And Jenny, were you going to say something?
No, that's great. Thank you.
Oh, okay. So, I mean, right now it doesn't look like we have any. Let me say my goodbyes and then I'll stop the recording. So anyway, Jenny, thank you again, you know, for a great presentation with so much information. I know my brain always spins after all of this, and I've listened to 9 of them and had lots of interactions with HICAP, but every year things change, and there really is so much information. So I do encourage you, you know, to use resources, HICAP again, you know, being the most important one.